important pharmacokinetic concept to discuss is bioavailability. And what bioavailability is the proportion or percentage of a drug that's administered that ends up in the bloodstream. So for example, if you give a drug intravenously, 100 milligrams of that drug, then 100 milligrams will end up in the bloodstream, and that's a 100% bioavailability. However, other dosage forms may not be 100% absorbed. So you could, for example, give 100 milligrams of an oral dosage form, but only 80 milligrams ends up getting absorbed into the bloodstream. So this is an important concept to think about. Now, there are a lot of factors that can impact the bioavailability of a drug. Big one can be the formulation itself. So for example, intravenous versus oral, but also if you do an extended release oral formulation, oftentimes that's going to be absorbed at a lower rate than an immediate release formulation. The lipid or water solubility of the drug will allow it to pass through membranes at a different rate and can impact its initial absorption. The time that it spends in the GI tract. So hypermotility, slow motility, nausea, vomiting, those types of changes can impact how well that drug is absorbed. Also, eating, for example, like we had mentioned before, can impact that. Age and sex can sometimes have an impact on the bioavailability of certain drugs. And disorders like the inability to absorb drugs appropriately, such as with certain GI illnesses, stomach illnesses. The degree of metabolism can impact absorption, particularly if it's given orally. So we had talked briefly about what we call the first pass effect. If you take a drug by mouth, it will get absorbed into the vasculature, but most of that drug initially is going to go through the liver via the hepatic portal vein. And some drugs are going to be extensively metabolized even before it reaches the bloodstream. And that can pretty significantly impact the bioavailability of the drug, which might change how we create dosage forms. Okay, so a drug that's extensively metabolized by the liver, if given orally, may only be available intravenously. So looking at variations of the route in terms of comparisons for blood concentration and time, intravenous is going to be our most quick time to peak concentration, if you will. So if you see we give a bolus or a singular large dose of a drug intravenously, it's going to reach optimum high blood concentrations quite quickly. Intramuscular is another parenteral or injectable form, and that's gonna peak usually a little bit slower than intravenous because it still has to get sort of absorbed through the muscle. And then, of course, we have things like our oral forms. So we have effervescent tablets, liquids, and tablets that are going to have a lower peak, lower rate of absorption. We still have to consider other ways that routes are going to be absorbed. So like, for example, suppositories. If they're administered rectally, there can be some systemic absorption that occurs. And depending on the suppository, that might be something we want to see. In general, vaginal suppositories are for local use only, but we can consider that from time to time as well as a way that we provide medications. So once the drug is absorbed and goes into the bloodstream, it then gets distributed into other tissues and organs in the body. And this is called the distribution phase. Now, the distribution phase is important because this allows the drug to get to the site of action so that it can exert its effect. Drugs can be transported in a number of different ways. They can move freely as a free drug, or they can actually move around in the bloodstream bound to a protein molecule, which will oftentimes get in the way of that drug getting to their site of action because it doesn't allow for as free distribution outside of the bloodstream. Other factors that impact distribution out of the bloodstream would be the size and the type of molecule. So large proteins and colloids are going to have a much harder time getting out of the bloodstream versus smaller molecules that can sort of move much more freely. So looking at plasma protein binding, which is what I was talking about a little bit earlier, drugs that are bound to these little proteins that tend to sit in the blood aren't typically going to be active, and they're not really going anywhere. So really the effect of the drug and clearance of the drug or metabolism of the drug is going to occur with the free drug form. Okay, so there are a couple differences that we tend to see depending on what's going on with the drug as it distributes throughout the body. Other factors that we want to think about is the permeability of the capillaries themselves. So in different parts of the body, there's different types of permeability. So remember, we have our blood-brain barrier, which we're going to talk about in just a moment, that has a much lower level of permeability. But we also want to think about things like the blood flow. So something that has a higher rate of blood flow will oftentimes have a larger movement, if you will. And then lipophilicity, or fat loving. So something that's fat loving will be much more likely to distribute into fat cells and sit there. So what this looks like is essentially we have our 4 areas of distribution, more or less. So we have our intravascular, so this is inside your blood vessels. We have our interstitial, which is kind of just the space between everything. Intracellular, and fat. Okay, so, and this is the general kind of breakdown of percentages of our body that these things have. And it can vary depending from person to person. So if a drug evenly distributed throughout all of those spaces, which typically doesn't happen with drugs, but for the sake of discussion, we look over here, there would potentially be equal amounts of drug in the intravascular volume, the interstitial volume, the intracellular volume, and fat. So for example, if you gave 8 milligrams of drug, there'd be approximately 2 milligrams concentrated in each of those areas. Now, if a drug is large, or a protein, for example, and it becomes confined to the systemic circulation and can't move outside of those capillaries, that's what you would see here. So you have a drug confined. So 8 milligrams of that drug will be in the bloodstream. Drugs that are very polar may not be able to enter cellular membranes. Remember, there's a lot of electronic charge in a lot of membranes. So those drugs might be able to move outside of the capillaries, but get stuck in the interstitial space and can't move into the intracellular volume or into the fat cells. Finally, if we have a drug that's quite lipophilic or fat-loving, it can accumulate and sit in the fat cells. So if you see here, this drug is essentially hanging out all in the fat cells, right? So this would be a little bit different than these other types of drugs, depending on the properties. So we also want to consider the blood-brain barrier. Like I had mentioned, it's a much more restrictive barrier compared with our standard capillaries, and that really allows us to separate the circulating blood and the extracellular fluid of the brain. Okay, so it's a physical barrier across those capillaries that are with the brain, but also can control what types of substances cross over. So this really helps to prevent large amounts of toxic substances entering the brain and causing bad things to happen. So really this can affect disease management in a couple different ways. So for mental illness, we need to find drugs that can cross the blood-brain barrier because that's really where our site of action is. We need to affect chemicals inside of the brain in order to see efficacy. So we need drugs that are able to penetrate into the blood-brain barrier easily. Now, if there's illness within the central nervous system, such as meningitis, that can cause inflammation, this can be almost advantageous for us in terms of treatment, because if we need to get antibiotics into the central nervous system with the case of meningitis, that inflammation will actually allow easier passage of drugs into that space. So how do we know that this blood-brain barrier is a thing? When did we figure that out? Well, it was about 1900-ish that they performed some experiments where they injected dyes into the peritoneum of animals. So that's the soft organs inside the body, and found that the dye would stay in the periphery or inside the body, but would not get into the brain or the spinal cord. And on the flip side, there were also experiments that injected dye into the brain and spinal cord of animals and found that it did not distribute into the periphery or outside of that area. So we know that there was some sort of barrier that kept that dye from moving into or out of that space, which goes against our standard principles of osmosis. So what we found when we actually were able to look at these in more detail is a highly selective permeable membrane. So if you recall, there are these things called astrocytes, and these are types of glial cells that surround the capillaries within the brain. So we have much more tight junctions, so the pores are much smaller. They don't really allow things to move through. We have some lipid-soluble pores, and we also have some carriers that allow things to move across the membrane using some energy, right? So if it's carrier-mediated, it's going to use energy. Whereas if you look at a standard capillary, there's going to be a lot more open, available pores. Lipid-soluble substances can move much more easily because there's less layers, but the things that get through here, through the blood-brain barrier, are going to be things like very small carrier-related items as well as highly lipophilic drugs. So really what we're looking at in terms of things that freely traverse the membrane are going to be water, gases, and small lipophilic molecules. We also have those carrier-mediated and active transport agents that are able to go through.